You should be an organizer now.
I'm organizing. Here we go.
Alrighty. This is just a nice example of anatomy. So it's a classic example of a classic Benjamin Felsen radiology sign. We tend not to see this, or I tend not to see this on the right side, but this one is a left-sided one. So here is the finding. This, by the way, is a normal right here. That interface is a normal so-called aortopulmonic pleural reflection, where the left upper lobe reflects over the mediastinum in that location. So that interface is normal. Then when we go up here, we see this interface. And that's fine so far, except over here it goes lateral. And then I'm going to make that bigger to show that the interface is well defined till about here. Then it disappears. So it starts to disappear at the level of the thoracic inlet when the thing no longer contacts aerated lung. So even though there's some opacity here, the sharp interface has disappeared at that point. And that is the so-called cervicothoracic sign, which indicates that the thing is located in relation to the thoracic inlet, and it's not something that's posterior in the chest. The other clue as to what it is that there's mild rightward displacement of trachea. And then when we go to the lateral projection, the first place we say it is not is in the posterior chest, which is up here, but rather here is it in part. So here it is, right here, but again, it's traversing the thoracic inlet. So this goes a couple of years ago, but it's a nice explanation for the finding, and the most common finding, all things considered, when we see that is a goiter. And yes, this one is a goiter. It so happens that the interface is actually produced by the left subclavian artery, which is expected, but it is displaced a little bit left lateralward. So that's the interface we see there. But the lesion is the usual lesion, which is a paratracheal goiter that extends, in this case, into the left superior mediastinum. So just a really nice cervicothoracic sign in relation to that. Okay, here is a case that, depending on when you see this patient or when you saw this patient, things would evolve differently, but this came to attention, well, the finding came to attention recently on the basis of a catheter placement. So here we see a catheter. There are other lesions related to the chest. The person has had surgery. There was a complication, so the chest tube and the pleural fluid is not related to the observation of the catheter. So that's a good observation. Here comes the catheter, it goes down. So one observation is that there's a little mild jog in the course of the catheter, and then it goes a little bit more medial than one would expect for a superior vena cava. So a little jog and a little too medial. So now I'm going to backtrack and actually go back to quite some time ago, and I'm going to show you the frontal and the lateral. Sorry, let me put them alongside each other. So yes, there's cardiac stuff, but ignore that for the moment. And let me show you two things. So first off, here is one finding right there. And the other one I will show you is here. And I'll show you why I'm pointing this out at the moment. And I hope you'll see this, but here is the aortic arch here. But there's another interface which is here and also here. That's relatively subtle. And that corresponds with that, which is a nice big azygous vein. So let me just get rid of that for the moment. So when we go back now in time to this bedside radiograph that you see there, You can't really see those findings there, but you can see them here. You can surmise what's happening here, which is there's a big fat azygous vein, and this catheter just went straight down that big azygous vein, straight down there. So this is the PA lateral that follows. And of course, you can see here we're going down the azygous vein. So it's a nice big azygous vein. So why is it a nice big azygous vein? So now you have to go back and look a little bit more. And analyzing this case, a couple interesting things. There's your big azygous vein. But going into the abdomen, we don't see an IVC in the liver. So there's interruption of the hepatic IVC. And the big azygous vein is carrying more blood flow. And we keep looking because other things come to mind. So here is a little SVC, a little persistent left SVC that goes down to the coronary sinus. But we do have an azygous vein over there, as you see there. And then I started thinking of Kanne's rule that says, if you see the vascular abnormalities, you've got to look for other things. And if you look at the lobation, you can see one bronchus on the right, but another bronchus, but really only two bronchi. So that is actually shown really nicely here, which will show you, this is a nice way to teach and depict bilateral hip arterial bronchi. So in relation to the corresponding pulmonary artery, this bronchus is hip arterial in relation to it. And this bronchus is hip arterial in relation to that pulmonary artery. So Kanne's rule, we have airway abnormalities and a bunch of vascular findings as well. So kind of cute case.
Howard, was there polysplenia?
Pardon?
Was there polysplenia with the?
You know, the spleen, I'll go back to that because the spleen looks odd. But I don't think the spleen has separate spleens. It's just like this very strange shaped lobulated spleen that almost looks like polysplenia, but it all seems to connect. And there is an association between hip arterial bronchi, bilateral, and polysplenia, but polysplenia usually is on the right side, right? So I looked at that and I thought, well, there's polysplenia, but then they aren't entirely separate, right?
Yeah,
Or,
it's like it was thinking about it, but didn't go through with it.
Yeah, didn't quite make it. And
yeah,
if I remember,
yeah, I think it's one of those. I was going to say that a lot of times these situs abnormalities just, you know, they don't fit entirely within the polysplenia or asplenia, you know, forms or frameworks.
Yeah. So just a bunch of interesting things that came together. Let me show you one more example, one more case of this patient. So this is a relatively recent CT, as you can see there. And we've shown cases like this before, but this one's a fairly dramatic example of this phenomenon where when you have chronic pleural disease, and you can see how much pleural thickening is present in that right hemithorax, there is a lot. How much fat we have as well. So hyperplasia or hypertrophy of the extrapleural fat in cases of chronic diffuse pleural disease. This is a really nice example of that phenomenon. There are foci of rounded atelectasis. I don't know why there's so much pleural thickening in the one hemithorax, but again, I'm showing it primarily as a really nice example of that hyperplasia or hypertrophy
And Howard,
of fat,
going along with that,
subcostal fat.
looks like there's a little hyperostosis of the inner margins of some of the ribs.
Oh, let's
Not
have a
the
look.
best example, but there's some. I think there's a little thickening more than some side than the other side.
Well, I think when you have volume loss of any thorax, you get the extrapleural fat getting kind of pulled in. I mean, you see the same thing with fibrotic lung disease. I mean, that's one of the findings you see with severe UIP patterns or whatever. You see the same thing where adjacent to the fibrosis, you see this prominent extrapleural fat.
Yeah.
And
I
even
don't know if it's
and pathologically, they even see it too. They see like a prominence of the fat adjacent to the fibrosis.
Yeah. So I don't know if it's real hyperplasia or hypertrophy. Those are the good words to describe it, but just a lot of fat there and pulled in maybe. It's very impressive, isn't it? And I thought I had a comparison, but, well, let's go back to, I do have a comparison. So here is a non-contrast CT, sorry. And if you go back here, there was some pleural fluid there, but that extent of pleural thickening wasn't present then. I don't know what that process is in the lung and the pleura, but that pleural thickening has evolved and the fat has really become pretty prominent, or yeah, excessive. So just a nice example of that, I thought. Okay, Jeff, those are my cases for now.
Thank you. Who would like to go next?
I got some cases if you want.
Alrighty. Okay.
So this is a case, a little bit of an older case, but I found it, of a young kid presented with severe shortness of breath and chest pain. I think most of us can see that the heart has cardiac contours, very globular appearance. Pedicle appears normal, but the cardiac silhouette's quite dramatically enlarged on the lateral. Can't see much, can't really see the quote unquote Oreo cookie sign, but nonetheless suggestive of a large pericardial effusion. He underwent a TAP, and their initial thing was they had a concern, I guess he had tuberculosis exposure, and they were concerned for tuberculous pericarditis. And so they got a TAP that was all bloody fluid, and they sent it for PAP. This was a post-TAP X-ray, which I think most of us would be hard-pressed to really say anything but an effusion. Maybe that's a node or some soft tissue there, probably some soft tissue, but this was just read as a kind of a complex effusion given the history. He then comes back a few weeks later. This is literally like 6 weeks later, which is pretty impressive. And now he has this with this very large soft tissue mass within the pericardial, intrapericardial soft tissue mass. You can see there's a lot more soft tissue associated with the compared to the prior study, just the amount of soft tissue that is developed in that short period of time. We have a very nice MR showing this. I don't want to waste people's time. I'll just kind of show a, oh, don't do that. Anyways, I'll meant to just quickly pull this up, but come on. But you can see this just very infiltrative mass within the pericardium. And stop. And we have, again, T1, T2, all that stuff. Delayed images real quick, if I can find them. Here, I think. Nope, those are not them. Sorry, guys. Let's see. This is it. So this is the post-contrast imaging, extensive uptake, very ugly. And he underwent a biopsy and presumably a primary pericardial lesion, although it could be metastatic for something, although he had no disease elsewhere. And the most common primary pericardial tumor is, of course, mesothelioma. Pericardium is, just like the pleura, is lined by mesothelial cells. So this was a primary pericardial mesothelioma. Here's diffuse PET CT. The relation with asbestos exposure is questionable. The biggest paper, which isn't that big, said 33% have asbestos exposure, but a lot of cases I've seen were in younger patients, and he died a few months after this study, unfortunately. But a nice case of primary pericardial mesothelioma. And I showed a case a few weeks ago or a few months ago about a primary pericardial angiosarcoma, which looks exactly the same. I assumed it was going to be another meso case, but that was actually a primary pericardial angiosarcoma. This case is interesting.
Hey, quick question regarding pericardial mesothelioma. I have one case radiograph from when I was a resident of a patient with bilateral pleural plaques and pericardial plaques, which I guess were presumed asbestos related. For everybody else out there, have you seen other cases of of presumed asbestos plaques in the pericardium?
Never.
Well,
Nope.
are they? I don't know how you differentiate between them being on the pericardium versus the, mediastinal pleural reflection. I don't know.
Yeah. I think it's because some of them were along the undersurface of the heart and looked more like confined to the pericardium. I'll try and pull it up, but
Yeah, I wonder if it could have been pericardial calcification for another reason. I don't think I've seen. Again, I have an N of 3 or 4 case of pericardial meso with any plaques anywhere or any pleural calcification anywhere. Even though that's what they say should happen, at least.
How would the asbestos fibers even get there? I mean, it'd have to go through the lung into the pleural space, and the fibrous pericardium is kind of tough.
I know. That's why, this case left a lasting impression on me. But it's the only one I think I've ever seen.
I mean, I think
So
it has
I
to be a similar mechanism to how it gets into the pleura too, right? I mean, it's supposedly the presumed
Lymphatics.
theory is that it's inhaled and they're little darts, and they just make it through the tiny ones that are like little darts. They're pretty heavy compared to most other particles. I mean, this is what at least the AFIP people say, is that, and they get peripheral and they lodge into the periphery of the lung and they make their way into the pleura. And that was my understanding. And they've done, initially they thought that the asbestos fibers didn't get into the plaques themselves, but they've done more recent electron microscopy studies that show that there are the fibers themselves, tiny little fibers in the plaques. And I would imagine maybe if they get into the pleura, it's a similar mechanism, but the pericardium, it's a similar mechanism, but I don't know. And again, that may be debatable.
You've got to get through more layers to do that. But what you said, right? What you said at the first was correct, in that so-called pericardial pleural plaques are actually pleural. So they're it's the adjacent mediastinal pleura that's involved with plaque. So I've never seen one on the undersurface of the heart. I've seen them along the left heart border, but those are medial parietal pleura along the mediastinum, not really pericardial, although they're called pericardial. It's quotation marks.
And so do you think just in general asbestos plaques get there through direct fiber penetration, or do you think there's another mechanism, a lymphatic mechanism?
Well, the only mechanism I've heard is that they work their way out to the periphery of the lung.
Yeah.
Some people think they actually stick out from the pleural surface and scratch the parietal pleura.
That's what I've heard too.
So, but I think that's all fanciful rationalization.
Yeah. But yeah, I'm not sure. And again, I think the studies that are out there are very small amounts of patients because it's such an uncommon tumor.
Right.
This is a case where the pulmonary findings aren't that interesting. He had a resection for this underlying disease. This is just a young kid who has shortness of breath, and you can see that superiorly, kind of just below the cords or at the level of the hyoid, there's this marked irregularity of the trachea. And then inferiorly, you see some soft tissue thickening, narrowing, and irregularity of the trachea. Initially, I thought it was going to be something post-intubation, but looking up here, this irregularity, and then I looked up his history, and he had a history of GPA. So this is, and he actually has had multiple evaluations of his stress scoping of the trachea showing ulcerations that have been biopsied, proving GPA. It's not, I remember Howard a couple of years ago showed a pretty amazing case with thickening and edema, and also this crazy looking bronchoscopy image showing this really ulcerated plaque or ulcerated mucosa, which was I still have, which was an amazing case. And actually show in my AFIP lecture, I give you credit. I say it's a nasty case, but here's just another case of tracheal involvement with GPA. And then last is, I'll just show this case on real quick with, oh, come on, stupid thing. Faster. I have it here. It's just it'd be quicker to show it with, but my thing is going to freeze now. Sorry, where is it? Here it is. Okay, so this is a young patient coming in and had an echocardiogram, which showed, if I can get this to play, that there's no patient information on the echo, but it's going to freeze. Oh, come on, man. Well, that's awesome.
You could just describe what we should be seeing.
Well, you should be, here we go. You would be seeing a mass in the left ventricular outflow tract, and there were multiple other masses as well. None of this is going to work well. And then I will show you the patient had those masses resected, and let's see if I can show some of them here. And she presented with multiple other lesions that were, here we go. Here's another one, very bright on T2 weighted imaging, and these were taken out. The first lesion I showed in echo was taken out a few years ago. She had 2 taken out. They were both myxomas. And then here is another lesion that grew, another myxoma, and she has a few others around in the left atrium. I think she might even have another one in the left ventricle. So this is a patient with multiple myxomas due to Carne's complex. It's complex, right? I always forget which one, if it's complex or triad, but I think it's Carne's complex.
It's complex, yeah.
So just a cool case. I've only seen one other case from this, and it was from the NIH of a patient with Carne's and multiple myxomas. So I'll send the MR and the echo cases. But all right, those are my cases.
Thank you, Seth. All righty. Who's up?
I can go now.
All righty.
All right, I've got beach. Okay, there we go. Do you see a PowerPoint? I was able to pull up this case pretty quick. So this is the case I saw as a resident, or was seen when I was a resident. And you can see there's bilateral pleural calcification, and then you have more, it looks like circumferential calcification. And all I have is the PowerPoint images. I don't have the actual study. But this is a patient who had constrictive pericarditis and actually went for stripping. So it wasn't just pleura. And you can see they have pleural plaques, and these look typical of plaques. And so it was presumptive asbestos in the pericardium as well. I don't know if they looked for ferruginous bodies when they did the pericardiectomy or not, but this was the case I was thinking of. So
I would call that diffuse pericardial calcification and not really plaque.
Yeah.
Yeah, the pleura is not discrete plaques. There's a lot of diffuse calcification, thickening of the pleura and calcium.
The pleura looks like plaques. I mean, don't these, you have soft tissue and then you have areas of calcification as well. And this guy had an asbestos exposure, but.
Yeah, I would think that, honestly, I would think that the pericardial stuff is from other inflammation, TB, something else.
Yeah.
It may be, I don't know. I've just never seen a case of proven pericardial plaque.
It also seems to be sparing the apex, which is characteristic of pericardial calcification from inflammatory things. You know, the apex of the LV is spared, and you've got that little deposit, I think, in the right AV groove there too. That's characteristic of usual kind of pericardial inflammatory calcification.
Oh, that's interesting. Is that true? I never. You're right. I mean, thinking about it, you do see sparing of the apex. Is that due because of the motion of the apex compared to other?
That's the rationalization, that it's the motion that's doing that.
That's interesting. I never thought of that.
I think that we can conclude nobody else has ever seen a case of asbestos-related pericardial disease. So I'm challenging my own assumption on this case now. That it's probably not. It's probably unrelated. But that's helpful. So, okay. Uh-oh. Don't freeze on me here. There we go. Okay. On to these cases. So this is one that just recently came in. This is a young guy who you can see has a left ventricular dilated cardiomyopathy and has a left ventricular assist device that's been in place for a couple years. It's been revised once. And he came in recently with low flow alarms, and this CT was done. And this is similar to one I showed a few years ago from when I was at Emory. And you can see that Remember, the outflow cannula has basically a tube within a tube, and you can see how there's narrowing, pretty substantial narrowing. And as you look even higher up, you can see how narrow the contrast channel gets. And so this was, obstruction, whether it's thrombus or if it's debris accumulating within the outside of the inner lumen and within this outer lumen, which is what this looks more characteristic of. Regardless, the patient went for surgery to relieve this. And so when they incised this outer graft, this was all just yellow debris and some sort of serous fluid that was in that. So it was not thrombus. And I don't know if you guys remember the other case I showed that was kind of similar to this, because I'd gone down the tubes on that case thinking it was thrombus, and that patient had been on lytics for quite some time without any improvement. But this is all just stuff in that outer lining.
And how are you supposed to differentiate? I mean, on imaging, what would...
Yeah. I think it's a good question. I think that sometimes this is so diffuse and it's so eccentric and it looks like it's just indenting it. I don't know. Right here, you're left with just like a little triangle. Yeah, I don't know. I think that's a very good question. And the only answer I had when we were having this discussion today was because it looked similar to the other case I had where it was just in the lining. So, but it's really interesting. I think the take home too is if patients don't respond to anticoagulation or lytics, that you have to think about the fact that it may not actually be in the lumen itself. It may be around it. Sorry, Jeff, you were going to say something?
Well, I was wondering, but I guess if it's outside the lumen, I was wondering, could it be like breakdown products of lysed red cells since they're going through this rotary pump?
Well, right. And that's the other question of how the heck does this stuff get in there? Yeah, I don't know.
Right. Oh, well.
But I think, yeah, the important thing to think of, especially if like the old case I had when they were on lytics and it wasn't doing anything, you have to ask the question, well, maybe it's not thrombus and it's just debris accumulating within the graft itself like this. So a good example of this. And yeah, Seth, to your point, I don't know. Other than having seen now 2 of these that kind of look like this, I don't have a great answer. All right, let's move on. Now this one is kind of exciting. This is a lady who, let me make sure I get these in order, had a dental procedure elsewhere that was then complicated by some sort of submandibular abscess. And at this point, it didn't have that much going on. And you can see her airway looks pretty normal. Then eventually at the outside hospital, this developed necrotizing fasciitis from this dental abscess. And it wasn't a retropharyngeal abscess, but you can see at the time of this study that she had profound pneumomediastinum and subcutaneous emphysema. And this was on the 14th. She had this CT done. And of course, here's the finding right here, which at least in part explains the pneumomediastinum. And this was not recognized on the outside study. She came here, had a follow-up study that I saw a couple days ago. And I'll show you the sagittal because I think it really helps to see it. And this is when I got involved and got kind of excited because you can see that this is the area of the balloon. You can see little portions of the balloon and just how focal the tracheal dilation is right there. And what's interesting is that and here you can see on the sagittal clearly, this looks like the balloon has ruptured the posterior membrane just with that focal outpouching now. And I just thought it was kind of interesting that over the course of 4 days, the pneumomediastinum had decreased, despite the fact that she had what looked like a pretty obvious tracheal rupture here. And you can see she's undergone debridement for her necrotizing fasciitis. And there was a little bit of discussion the next day because I saw this radiograph and they repositioned the ET tube and the pneumomediastinum is almost completely gone and the balloon is no longer massively over distended as, here it was a little bit more distended. Maybe this one is where it was over distended. But anyway, they repeated the CT the next day because there was some doubt. Was it really ruptured or was it just over distended? And you can see here that even on this one, when the balloon is deflated more, that there definitely looks like there's a tear. And so they went and bronched her and they did confirm that there was about a 5 centimeter long linear tear in the posterior membrane. Not exactly sure what this angle is, and these are the best pictures the bronchoscopist could get. But they're actually going to let this try to heal on its own because there was some of this granulation tissue here, and they've since trached her. I mean, clearly you can see her lungs. She has some acute lung injury related to her sepsis and her necrotizing fasciitis. But good example of just an iatrogenic tracheal injury. And I guess the one question is it just from, is it the physical intubation itself that caused the tear, or was it the overinflation of the balloon? And either one could cause it, but clearly the balloon is occupying too much space there. And then this one I'll show really quick. Pretty classic case. This is a patient who had this radiograph, and she was referred here, and you'll see when you see the CT pretty quickly what the diagnosis is, and just some kind of vague upper lobe predominant opacities. And the more you look, you can see there's probably some more discrete nodules and nodular opacities you can tease out. But this is one of those kind of ant minis from across the room that you can see it, that you have this nice just cloud-like opacity in both upper lobes. It's sparing the interlobular septae. And of course, she's somebody that has end-stage renal disease and she's had prior renal transplants that have failed, and she's back on hemodialysis. And she had interesting, at another hospital, she had an episode of pulmonary hemorrhage, and she was transferred here because they thought her pulmonary hemorrhage wasn't resolving. But these, this to me looks like metastatic pulmonary calcification, pretty classic. So then wouldn't expect this to change in this setting. And she was asymptomatic at the time that she was transferred here. So, but I think this is, I'm guessing everybody would agree that this looks like a pretty characteristic case of metastatic pulmonary calcification.
What sort of attenuation can you get out of those lesions?
Well, let's see. Not too high, obviously. There was maybe one area where there was a little bit more.
Mm-hmm.
I thought in the right middle lobe, maybe there was a little bit more discrete. Yeah, like right in here.
Yeah.
There's some calcification, but I think it's it's just more amorphous cloud-like at this point.
Uh-huh.
But it does have the typical look where it's sparing a lot of the interlobular septae. Like here and here, this, as it's been described, the photographic negative of pulmonary edema, at least on CT.
So what is, so as a sequela of pulmonary hemorrhage and stuff like that, you think this is very, very fine calcification? But this actually looks like less than soft tissue density here. So it doesn't have the density of muscle.
No, and yeah, I agree. And so
I'm just wondering.
I don't even know if they had if the hemorrhage was true, like true hemorrhage. Yeah. If that was just some sort of red herring or something.
Right.
Let's see. Yeah, I thought I had the other one too. I guess I didn't pull it over to my computer. But I think it's a pretty typical distribution, certainly with the upper lobe predominant distribution, just because of the difference in oxygen tension that causes it to precipitate out in the upper lobes.
Uh-huh.
So, but she was completely asymptomatic.
Yeah. I don't think I've ever, we've shown a few of these over the years, but I don't recall one in which one can potentially see opacities on radiography.
Let me, Jeff, go ahead and have somebody else show. I'll retrieve the other one from my server.
The best is
I have to review
my
some
phone scan
names.
It always lights up.
Yeah.
All right,
Yeah.
David, do you want to go while Travis digs around for it?
Yeah. So, can people see a röntgenogram?
Not yet.
How about now?
Yep.
Okay. So this person presented to an outside clinic here with some dyspnea and had this radiograph, and you can see that there's just some subtle patchy consolidation here, nothing too striking. But a few days later, this is a week later, you can see that things are now pretty impressively worsened here, and there's probably some accompanying pleural effusion. Lung volume has decreased, and this is what his CT scan looks like. He's got a lot of patchy consolidation. and quite a bit of this stuff is trying to be peripheral. So it's way out here against the edges. It seems to be basal predominant, but there's big components in the upper lungs as well. And this was bronched and biopsied, and this was an eosinophilic pneumonia. I think they got 70% EOs or something like that out of his lavage. I'll check those numbers. And he did have a mild peripheral eosinophilia, so he had a blood eosinophilia too, but it was fairly modest. He had a high white count, and people's first presumption was infection. His total white count was around 18,000, but within that, the eosinophils were elevated slightly. So he did have eosinophilia, absolute and relative eosinophilia, and eosinophilic pneumonia. So they looked hard for vasculitis, and they did not see anything that would go with vasculitis. So this is presumed an idiopathic eosinophilic pneumonia. He was put on steroids and felt better within a few hours of getting corticosteroids, and is going to go back home to Australia. So here's another person. This is a radiograph before this person became symptomatic from last year, from 2017. And things weren't going so well this year. This person presented with this patchy consolidation, a lot of respiratory distress, had worsening over several days. So here's our last radiograph on this person with even denser stuff, cloud-like in both upper lungs. Had the CT scan fairly early and has this patchy consolidation, which is mostly central and seems to be around airways. Person was coughing up some blood, was bronched, and they identified pulmonary hemorrhage here, and there were biopsies done. The day after the person presented with their respiratory problems, the skin lesions developed, some purplish skin lesions all over the place. People were thinking about the possibility of fungal infection. Those were biopsied, and they found that this was a eosinophilic vasculitis in her skin. And she now has a diagnosis of EGPA, or Churg-Strauss. And she had on bronchoscopy, I think she had some EOs, but she had a lot of hemorrhage. And I don't know whether they made a diagnosis of vasculitis in the lung itself. I'll get that information before I post this case. It was accompanying pleural effusion. So 2 people here with eosinophilic lung conditions.
And David,
I'm sorry?
The first guy, was he a smoker?
That I don't know. I'll go back and check that history. Why? Or what are you thinking of?
I don't know how acute his symptoms were. I mean, acute eosinophilic pneumonias, which are usually really acute types onset, have been associated with new or binge smokers. There have been a couple of papers. The one I remember is I think 2005 in JAMA. It was like 18 or so soldiers, American soldiers in the Middle East, who developed eosinophilic pneumonia, and they were all smokers. I think all but 2 of them were new smokers. And they respond very quickly to corticosteroids, hours, day at most. But they can. We had one young woman here. I think I showed her case years ago. She was 18, started smoking with her friend out New Year's Eve, came in really sick, had consolidation, small pleural effusion, looked like almost like an edema picture, but didn't fit right. She was in the ICU, and eventually when she got bronch, they got the eosinophils, gave her steroids, and she's back on the floor within half a day, kind of picture. Because he responded rather quickly. So I was wondering if this was acute eosinophilic pneumonia or just eosinophilic lung disease.
Well, they looked for the usual culprits, I think, in him, and they couldn't tie it to anything. I don't think he had a history of asthma. The second case I showed, the EGPA case, that person did have a history of asthma, and had a higher eosinophilia too in the bloodstream. So here is, but I think your point sort of amplifies the fact that people with eosinophilic lung disease are very sick. We tend to think of allergic conditions as being benign compared to infections. So when somebody comes in really sick and they've got lung disease, people presume infection, but eosinophils make people very sick. So you know, their presentation overlaps with severe infection. So here's a person, I think in her 40s or 50s, who has this asymmetry of the lungs here and a biggish heart. And here's her CT scan. I don't really have a formal chest radiograph. I just have that scout view. She's got this hugely dilated main and left pulmonary artery, and she has severe pulmonary hypertension and a very hypertrophied and dilated right ventricle, flattening of the septum and so forth. And she has no right pulmonary artery. So this is a congenital interruption of the right pulmonary artery. Then she's got this patchiness in her lungs. So really looks like mosaic perfusion here. So I don't know, what do you guys think? Do you think the cava is being compromised by this liver here, or I think it must be, because the contrast is fairly bright when it's opacified.
Sure, looks like.
Yeah, looks like.
Okay, I don't know. Have you ever seen dilated ascus in association with varices before? We know varices will do strange things like communicate with inferior pulmonary veins. Any place to drain is legitimate when you're a distended vein. You know, you'll take anything. I didn't see that in this case.
Yeah. David, I've also seen big azygous veins just in the setting of cirrhosis in general, because I suspect there's more shunting, sort of pre-portal shunting to the systemic circulation through collaterals, just to bypass the high pressure in the liver.
Yeah.
Yeah. I
Okay.
think so.
Sorry, I was
Very
gone. My audio had died, and we were offline for about 5 minutes.
Jeff, let me show the this other metastatic pulmonary calcification case really quick. So this is the one that I showed several years ago. But Howard, in reference to your question,
Sure.
you can occasionally see them on the radiograph. And here too, the clue is he has a hero catheter. So this is going straight into his hepatic veins and his IVC, because he had no SVC or IVC left. But even on the radiograph, you can see how it looks like some of the interlobular septae may be spared. And here you can see.
Oh yeah.
Yeah.
Gorgeous.
Now this one, there's a little bit more confluent calcification, but to your question, David, you still don't see anything really, with the exception of a couple little flecks on the soft tissue windows. But this also has that upper lobe predominance from the difference in oxygen tension and difference in pH causing precipitation.
Yeah, that's beautiful.
Yeah, this is
you
the
could
best
use
one I've ever seen.
Yeah, you can teach rosettes on CT and radiography in this patient.
Yeah, so
Call them the rosettes.
You see the same rosettes in the pulmonary hemorrhage. So I think you could view this really as the calcified pulmonary hemorrhage. I mean, I think that would.
So,
But
all right.
Beautiful case. Yeah, that's right.
Okay.
Right.
Okay, I've got a few here. So following up on last week, I showed you that delayed diagnosis of a diaphragm rupture many years out with a herniated liver. So we seem to be having an epidemic of diaphragm problems in the Midwest. So this is a young man who crashed his car while intoxicated, I believe, wasn't wearing a seatbelt, and presented with a chest radiograph that looked like this. And you can see what appears to be a gastric fundus up in the chest, and you can still see the lower lobe vessels behind it and still make out the heart. So one would probably argue, based on the frontal projection, this is an anterior location. So it could be a congenital hernia, Morgagni hernia, or something like that. But in the setting of trauma, of course, you can't make that assumption, especially if you don't have old imaging. And probably best, let's see if once it loads the stack, I'll show the coronal. Make a coronal here. But you can see that indeed there is stomach in the chest, but also within the pericardium. And we see pneumopericardium. I'll go back to the axial again and show you the defect here. So this was rupture of the stomach into the pericardium. And right here is a nice tear in the pericardium. We see some gas, and there's fundus. The right ventricle with some mass effect on it. He's got some other injuries, but this is the main reason I'm showing this. I'm sorry, she. But so this, I think someone showed one of these, I think, at one point. But I've not seen an intrapericardial rupture before. And then,
Wow.
Yeah. And this came.
So Jeff.
Yeah.
Jeff, the way to a woman's heart is through her stomach.
Okay. Ouch. All right, and this came 4 days before, so this is more of a traditional one, but this is a great one with the classic findings. So you abnormal diaphragmatic contour, you have the contusion, patient clearly severely injured. This patient was ejected from a car as well, but this is probably the best example of a dependent viscera sign I've ever seen. You've got gastric fundus here up against the posterior wall of the chest, little colon coming way up here, abnormal breath sounds for sure, somatolactatic lung. And this was a 14-centimeter defect in the diaphragm. And it's interesting because in this one, it's hard to see the defect because there's no diaphragm left. It's such a big tear. But you look here at the cruce, and the surgeons like to know whether the junction of the stomach, the esophagus and stomach is intact, and we can see that is indeed intact. And there is some cruce in here, but there's probably blood in the cruce there, and you can't even see the diaphragm. It's just this huge defect. So we've had 3 diaphragmatic ruptures in about a course of 10 days. This is a cool case, and I would love all of your thought of this because we don't really know how to explain it. I can't remember why we got this scan. I think she has lupus, if I recall, and has this funny vasculature in the chest wall. You see all these little tiny vessels, and you can see them coming off the internal mammary system, going in the extrapleural tissues as well as the chest wall. And what's kind of cool is they anastomose into this middle lobe through all these tortuous vessels and then follow this large vessel back all the way here to the hilum, and it is coming off the right middle lobe pulmonary artery. So it looks like it's a systemic to arterial, a pulmonary arterial shunt, because to me this looks like mostly systemic arteries coming back. And if you look along the fissure, you see how thickened and nodular it is. I think those are all vessels running along the pleural surface. So didn't have a good explanation. What else is a little bit odd about it is you've got some abnormal vasculature even on the other side of the mediastinum, even out on the coming off the left internal mammary system. It just seems like there's more flow here than usual. May just be large intercostals, but it seems like there's maybe some here along the pericardial surface as well. So do you think this is just some congenital malformation? It looks more like acquired vascularity to me than some sort of congenital thing. I mean, it's going subphrenic here, just all on that pleural interface.
So Jeff, no history of severe infection, no right middle lobe infection?
Not that I know of. I mean, it's possible. Like you're thinking like a pseudo sequestration.
Well, yeah. So anything that would have irritated the pleura and then caused vessels to cross the pleura because of inflammation, like blood in the pleural space or infection.
Yeah,
something.
No thickening. There's no findings of trauma. I mean, I guess it's possible. That would be a good explanation. And the fact that it's isolated to one lobe, it just doesn't look like your typical anomalous vessel. I mean, it looks like multiple different vessels. So that neovascularity that we associate with a pseudo sequestration.
And no rib fractures on that side.
Yeah, we looked for all trauma. It's a young woman. We didn't have a lot of history, but we know that she did have lupus, so it's possible she developed lupus pleurisy or pleuritis, I guess, at some point, or maybe flares of lupus-induced pleural inflammation, and maybe over time led to this.
And it's all arterial and not venous.
As far as I can tell, because we're really in an arterial phase here.
Even in her right breast there, you can see there's some it's like superficial collateral that dives down too.
Right. Recruiting stuff, but if you can follow it all back to the internal mammary artery, because there it is, and you see us how big it is. It's a really juicy vessel, and then these all are coming off of this vessel here, and so it's not pulmonary venous arterial drainage to the systemic veins, but rather it's all these little branches. So I think it's because higher pressure. I think it's coming from the outside in and probably just mixing with the pulmonary artery.
Yeah. I saw a case of this before in a man who had had a spontaneous pneumothorax and had tube thoracostomy and probably had some hemothorax as part of that. He developed all this chest wall vessel penetration of his right upper lobe, and it forced blood backward in the pulmonary artery system, and it also connected to the pulmonary venous system. So once again, anytime there's a pressure gradient, you can form a collateral pathway, and that clearly was not present before his spontaneous pneumothorax, because during his pneumothorax we had radiographs that showed very clean pleural surface, clearly separated from the chest wall. There was no bridging back at the time of his pneumothorax. Mm-hmm. So I think you can easily force blood backwards against the pulmonary artery pressures, and communication with both veins and arteries is I've seen before.
Okay, makes sense.
Yeah, so it's basically a fistula, probably congenital.
Congenital?
Well, don't you think? Is that what you think, Jeff?
No, I think it's probably acquired.
Or acquired.
It's sort of all these little tiny vessels, as opposed to like a sequestration where you have one big vessel right. The aorta. It looks more like a pseudo sequestration, but without underlying inflamed lungs. So that's why I wonder if maybe was the sequela of a lupus pleuritis.
Yep, prior pleuritis. Okay.
The pleural surface was irregular there. That does suggest there was prior inflammation, and this is, as you're saying, Jeff, this is neovascularity. This is not congenitally factory installed.
All right, and then real quickly, I just wanted to show this case because this is just one of these ones you don't see all that much. So this patient is a diabetic, poorly controlled, type 2, had a foot ulcer, had a bunch of problems, developed bacteremia from Enterobacteriaceae, ended up with a debridement, then a BKA, then became septic, and then they noticed some swelling in the neck, and it then slowly became erythematous. So they did this neck CT to look for abscess or whatever, and you can see there's all this gas and edema in the lower neck tracking along sort of this platysmus sternocleidomastoid into the upper chest. And I'll switch over to the chest CT, which just shows the rest of it. But it's quite impressive because there's gas inside the bone marrow space of the clavicle, the manubrium, so it's going through the joint, and then there's an abscess in the prevascular mediastinum, and just all this chest wall edema and all this inflammation. And yeah, they had to go in and debride a bunch of this stuff. They resected the bone. So this is a abscess that then caused direct spread in osteomyelitis, and just really, and they had to go drain this thing. But all related to just sepsis, presumably from the foot ulcer that then seeded everything else. But I don't think I've seen this much gas in a bone before, so it was quite impressive. So, yeah. All right, guys. Well, thank you very much. And
thanks.
Talk to you next week.
Jeff, I'll put this recording onto Dropbox as soon as it's done processing.
Put the parts together and we'll get it done. Thanks for doing that.
Great. Thanks everyone.
Bye-bye.